Hello, thank you for your patience. Welcome to the Risk in Acute Frailty Care webinar presented by Mandy Rumley-Buss, who is an associate to the Acute Frailty Network. First, we have just a few simple housekeeping points. This session is being recorded and the recording will be available to view on our website shortly. All attendees are muted to avoid background noise during the recording. At the end of the presentation, there will be the opportunity to ask questions. If you have a question, please use the raise your hand option in the panel on the right-hand side of your screen. Alternatively, you can write your question in the question section on the panel. During the Q&A sections, we will unmute you to ask your question in person. Thank you, and I'll now hand you over to Mandy. Thank you, Mandy.
Hello, everybody. Apologies for the slight delay. There's been technical problems getting connected. So it's really delightful to hear that so many of you are out there. And we're talking about a risk in acute frailty care. What I intend to do during this is to talk about, sort of examine the notion of risk in healthcare and what we normally do. But this might be slightly different to what you're expecting, because what I really want to do is, yes, I want to focus on frailty, but I want to look at the human factors associated with risk and how we can maintain the risk that we naturally carry with patients with acute frailty, yet assure that our safety is maintained. And I want to open it up for you to engage in how we might be able to do this and make errors, because we're naturally human and will make errors, and yet continue to take risk and continue to be safe. And what part of the risk does our patient and the carers take? So that's what I intend to do. So forgive me and indulge me, if you will. I'm going to just talk through some facts and figures around risk and just generally paint the picture of risk before I get into, let's look at this in relation to frailty. So if we look at the size and the scale of the patient safety problem, not just around frailty, but across the NHS, we deal with over 1 million patients every 36 hours. And studies show that 1 in 10 patients are harmed while they receive care. That's 100,000 patients every 36 hours. Most of this is quite minor, but sadly there are 3,000 avoidable patient deaths reported each year. So the problem is quite significant, and we have huge areas of our trusts given over to risk and governance. But I want to take that a bit further and say, what about us in relation to this? Make risk really part of our problem and our solution. So the causes of errors, if we look at what the causes of errors are, Graeber did a study in 2005 and found that lack of medical knowledge was rarely a cause. Cognitive errors, so on the part of practitioners who didn't have some understanding, perhaps premature closing consultation, with some problems. There were errors that were found to be no-fault errors, and that was due to perhaps unusual presentation or a deceptive patient, as they're called, uncooperative patient, in which there was no fault found and the causation. But however, I would say if you look at no-fault errors, there are people, patients involved, clearly, and then we have system-related errors. So if you look at the causes of errors, currently our focus on looking at errors is around event reporting in order to learn from unexpected events. And we must obviously keep doing that, and it's really important that we should learn about them. And if you look at the iceberg kind of incident, for every one of those 3,000 deaths, there is estimated that if you have an accident in any way, you have at least 300 near misses. So if you look at the iceberg, what you see on top of the iceberg is there's a lot more below the surface that's going on. And in the same way, if we look at the risk and we look at reporting, what is reported, there are many other incidents that go unreported across the NHS. And so what we see is really the tip of the iceberg. So we see incidents where patient harm happens, we see near misses, we see unsafe acts, hazardous conditions. But predominantly there are issues where we have accidents just waiting to happen. And what is really important is how do we uncover and expose the rest of that iceberg when we're looking at risk. So our lesser events that often don't get reported provide us with opportunities for learning. But because there's such sheer volume, they represent sheer sort of substantial waste, frustration and rework. So we have a whole industry around, and quite rightly, managing our risk and responding to the events that happened. And I'm not decrying that. I'm not trying to say that we should be doing anything differently. However, there is a myth that we should get to the root cause. The root cause will let us know, let us learn. And what we must remember is there are multiple causes to any event and any accidents. And it's not about finding the one root cause. Very often, when we're forced down the route and the way that we report, we are looking for that one root cause. But there are many causes, and we must remember that involved in all of this are human factors, and that's what I want us to move on to. So if we look at the new view of human errors, we say that human error isn't the cause of events. When we make human errors, it's a symptom of deeper trouble in the system. And it's not the conclusion of an investigation, it's the beginning. So human error may lead to the beginning of an investigation. And events are often the result of multiple causes. So in many ways, when we go down the route of reporting and finding a root cause, we are honing in on one specific cause rather than looking at the multiple causes. I'm not saying that is not the intention of us doing, it's what can happen. So that might not be our intent, but that can be what the result is. So what are these clinical human factors? And Ken Catchpole in 2011 said that what clinical human factors are, what we should be doing is enhancing our clinical performance through an understanding of the effects of teamwork, tasks, equipment, workspace, culture and organisation on human behaviour and their abilities, and the application of that knowledge in clinical settings. So that's one sort of definition. Apologies about the phones ringing in the background. So that's one definition. So what we want to do is, if we look at human factors and take that approach to risk, we really focus on the individuals, and we really focus on the team, and we focus on what we have got and the equipment and the areas that we're working in order to resolve that. So if we look at what is the definition of human factors, it's anything that affects a person's performance. And human factors refer to environmental, organisation and job factors, and human and individual characteristics which influence our behaviour at work in a way that can affect health and safety. So a simple way to view this is to think about three aspects. You've got the job, the individual and the organisation, and how the three impact on people's health and safety related behaviour. If we start to think of safety and risk in these terms, we change the way that we focus. So in frailty, just like in any other area, this is perhaps a way we can think about to move forward. The RCN have done quite a lot of work around human factors, and they look at it in relation to when we're looking at patient safety. We should start with an understanding of the things that support or hinder the way that people work. And the premise will always be that the design of our workplace, equipment and working processes should be based on human abilities and characteristics, and how we process information, communicate, make decisions and remember things. Rather than what happens is that we expect people to adapt to the poorly designed world around them. And I think what's really important when we're working in frailty and we're looking at our pathways, risk within that, what we should be looking at is in what way can we design that pathway? What are the human factors that could pose risks to our patients and to ourselves and the organisation? I'll come back to that. In the RCN, I quite like, they've got this little diagram, and if you look, I don't know if I can get the pointer, you've got the patient quite rightly in the centre, but what you have is around in red, you have the person factors that might impact and lead to an accident in the patient. So our decisions, the fact that we could be distracted and do something incorrectly, the dexterity with which we perform a task, and our situational awareness all can impact and have create a risk because we do something wrong that impacts on the patients. Equally, if you look at the outside ring, if you look at the way that they've presented this, they say all the outside factors equally support us with our internal factors. So we can easily become distracted when we're stressed, when we're tired. The work environment, the fact that you can hear people knocking on the door while I'm presenting and the phone ringing while I'm presenting, all serve to intervene and put pressure on us that can lead us to make errors. Leadership's vitally important, and teamwork and the fact that we're all part of a team and we're all working on this together all can impact on the patient in the centre and whether or not we pose a greater or lesser risk to our patients. So when we look at risk from a human factors perspective, we look at what is it that we could make an error in, for example. So all our internal things in that red box, and we know that some of those external things will have an impact that lead us to have a more likely chance of having an error. So what can we do if we work from that premise to reduce the risk? I think the other thing that's important, so I'll just go past that. So when we think about how this applies to frailty, acute frailty patients, our patients, particularly those with a cognitive impairment, present a risk. Our patients, because they're frail, because they're older, because some of their systems are not functioning as they present to us, there's a real risk, greater than in some other areas, of misdiagnosis, communication errors, and the fact that something can and it will go wrong, and errors can occur. That's quite difficult to accept sometimes, that we should be able to accept that errors can happen. If we accept that errors can happen, what can we do individually and as a team and as an organisation to work with them and check what might go wrong? If you look at the root causes, things why they go wrong in this sphere of frailty, often it comes back to patient issues that couldn't be prevented. So ageing processes that could not have been foreseen. That actually came out of a report that was done within the Royal College of Nursing and said that the root causes into why things go wrong in frailty is that there were patient issues, they couldn't be prevented, physiological factors regarding aging that couldn't have been foreseen. Well, I don't agree with that, because the one thing we do know is our people do age, and there are physiological factors that do happen with age that could be foreseen, and we could support people in preventing against that. So if you just think about the fact that our muscles age, our quads decrease in ability as we get older, we can do simple things while we're younger enough to support us not getting frail and keeping our quads, this is just very simple, going for longer. So there are things that we can know will definitely happen because of ageing. Patient issues where people can't communicate well, we know that's a factor in acute frailty. So we know that that's the factor, so why aren't we looking at risk from a different perspective rather than waiting until it goes wrong? What I'd like to do is just share with you, so what can we do about that? Well, we can share the risk. So we have a choice when people come into hospital, in that we can share the risk and involve the patient and carer, or we can take a paternalistic approach and think, this patient's not safe to go home, so they'll stay in hospital, because we believe that they're not safe because they're at risk of falling. Whereas the patient may feel that, yes, they're at high risk of falling, but actually, although they're at high risk of falling, they do not perceive that to be sufficient reason for them to stay in hospital. They are happy to live with that risk. So we see that in every day with older people, that people are happy to live alone without help, whereas we perceive, and when we you could argue, take a paternalistic approach. We perceive that they need this and we can't let them go home without that. But if we took a focus and we looked at human factors, because we can take that focus, and I think that's absolutely right and proper, and we should be looking at our patients and their carers and how we're involving them in the risk-taking that we're expecting. But equally, we could understand and focus on the human factors in our work and mitigate against some of those errors. What I'd like to do now, and Paula, if it's okay with you, is just unmute you for a moment, just to see if there's any questions at this point, because then I plan to sort of go on to talk more about human factors and what that means. So is there any questions at this point in the presentation?
Okay, probably the best thing to do, Mandy, is if anybody wants to raise their hand, if they've got a question, I can then unmute you, or alternatively, you can type in the question. So just give everybody a couple of minutes to do that. One gentleman's raised his hand, David Brown, so I'll just unmute you, David. Hello, can you hear us?
Yeah, hi everyone, thank you. I'll just stop that phone ringing behind me as well.
So David, what was your question?
There we go. So my question is about this idea of risk sharing and involving the patient and carer. So it's a topic that we've discussed in Plymouth Hospital, where I'm from. There was something that was quite high profile in the news recently, though, about a council who was prosecuted for allowing a patient with capacity to take positive risk that led to a death. And that's something that people are aware of, and so there is a concern about, even if patients have got capacity, if we are complicit in allowing them to make bad decisions, somehow that comes back as a failure of your professional responsibility. So can I just ask about sort of insights into how this might be different from that national case that involved a council, and how we try and help professionals to take that step?
A very good question. I don't know that I'll be able to answer, but I will have a go. I think you're absolutely right. I don't know that case, but being complicit in patients' decision-making with people with capacity who make unwise decisions. So people with capacity, we all have a right to make unwise decisions, and we all do that every day. I take an unwise decision to cross the road when the lights are red, and I can see cars speeding along because I think I can beat them. We do unwise things, but we have capacity to do them. Now, what sometimes happens, though, is when people make unwise decisions, our documentation of how we've gone through that process is often lacking. So I don't know the Plymouth case, the case you're talking about. I don't think it was a Plymouth one, was it? It was a national one. I don't know.
In the middle, yeah.
I don't know enough detail, but it might be that we as professionals weren't able to show how we had recognised that the person had capacity, recognised they could take that risk, and we took this step or that step to mitigate against potential harm that we could see. So it might be that that didn't happen. I think with understanding human factors, whilst that wouldn't prevent those cases, what it does is it shows a presence within your organisation, within your teams, that you take the fact that all of us can err and be human seriously, that you are looking at that, particularly with the most vulnerable group of patients that are coming into our pathways, and that you are trying to identify those risks and proactively do something about it, rather than allow the risks to happen, if that makes sense. Because very often, and what I do disagree with in our culture, and I understand why, is we are responding to and undertaking root cause analysis to an issue that has arisen in which something went wrong, or that somebody in our own teams, we're raising issues quite rightly so that we can highlight this is a risk to the organisation, And if it happens 20 times, you know, and 20 people bring it up, the organisation recognises this is a significant risk. I'm not suggesting 20, but you know what I mean, a number of times. But this is a significant risk, and we ought to do something about it. So I think understanding human factors leads you to be proactive rather than reactive in managing risk. But I do think, that I don't know the case you're talking about, and I'm really interested in that. But we must allow people with capacity to make unwise decisions. I don't like that. I've been involved with caring for people in which they have made hugely unwise decisions, in which they ended up being admitted to hospital, which I could have predicted that would happen because they continued to make unwise decisions. In a previous place I worked, this became such a problem with a particular individual who she couldn't manage at home, was sitting in a chair, insisted, she had capacity, she'd had several capacity decision reviews, and was always found to have capacity to make her unwise decision to remain at home without care, and didn't really manage to provide self-care, would then end up with a wound. She had leg ulceration, ended up with leg ulcers becoming infected. When they became infected, she would have treatment with antibiotics. She wouldn't be able to care effectively. The nurses would go in to dress the wounds, repeatedly find wounds dressings off. They were going in daily, the dressings were still off. There was leakage of the wound around. The patient would end up with sepsis, end up in hospital. The hospital would then say this is an issue, even at one point saying this is a safeguarding issue. And I became involved at that point because everybody was concerned for this patient's health. So I actually went in with that patient, spent several times going over the risks that she was holding, even so far as to tell her that she may die of sepsis, and was she aware of that. And actually we drew up in our practice at that time, our GP practice, we drew up a contract which stated what the risk was and how we were advising her against it, and we each signed it. And it was taken to the GP practice solicitors, who said, yes, we think this would work. But very interesting, the minute that happened, the patient then, I think the signing of it actually promoted this, but the patient then changed her mind and accepted all help. So it was something very powerful about documenting that unwise decision and our understanding that it was an unwise decision and her recognising that and us signing it together that unlocked it. I don't know if that answers your question, David, but I suspect this will run and run, just judging by the number of you on this call. So it'd be an interesting one to explore further, and I'd be interested to have any of your emails, any follow-up, and set up a little group to look at it after the talk today. But I don't know, as I say, I don't know that answers it, David.
Yeah, I suppose it was more whether there is literature that we can refer people to that is supportive of this. I know I'm familiar in mental health around, you know, the large amount of work that's done around positive risk taking. I'm just not aware that there is such a lot of literature available in physical healthcare, but it's the way that we're starting to ask people to think and behave. And we can obviously read the mental health stuff, but if there is specific stuff where there are, you know, national bodies saying, you know, it's okay to take positive risk, in fact it's encouraged, and these are the consequences that we recognise, and this is the protection that you have as an individual in that system, that would be helpful to have.
Yeah, well, I'll take that on board. I don't know if anyone else has got their hand up that might have heard this and be able to respond any further, but certainly I'll take it outside this presentation.
Yeah, there's no hands up at the moment, Mandy.
Okay, but I think that's a really good point, and thanks for that, David. I really think that's worth exploring. I wasn't aware of that case. Nevertheless, I do think, and I regardless of that case, I think that's why in many places there is a paternalistic approach in which we, and I'm now speaking on behalf of an acute trust, we feel that this risk is too great for you to go home, and yet the person has autonomy, has capacity, and wishes to make that unwise decision. and how do we allow that to happen? And I do think we have to be careful about how we document that, and how we document such sort of plans, so that it's transparent and explicit. So I'll come back to that in a moment, because I think that's absolutely fascinating. What I want to do now is really look at the human factors. So now I've said what they are. Let's have a look at it from a very quick snippet of human factors. So if we take a human factors approach, what we'd focus on is sort of being situationally aware. So every day at work really becomes situationally work, and that situationally aware, what that means is that we can think ahead, we can plan, we can identify the risks before they happen. What happens currently is there's stressors within the workplace, and that leads us to a right now, get on with it, reactive culture, rather than thinking the situation through. And we can lose sight of the bigger picture and result in tunnel vision. We're really starting to look at situational awareness and the human factors within emergency circles, and there's quite a lot of work going on in certain areas around this. And indeed, some of you in the audience might be having some human factors training as well. Obviously, the other thing that we need to think about is our perception and our perception, our understanding, our cognition. We can lose our perception, and oh dear, sorry, I've made a spelling mistake there. And with the benefit of hindsight, we can see how we could have made mistakes. So we're looking at hindsight is a wonderful thing when we're looking back at incidents. But human factors help us to recognise when this might occur. So if we're situationally aware, if we know our perception and our cognition can become clouded, what can we do thinking ahead to stop that? So you all know situations. I found it myself. You're with colleagues, you're working in very demanding environments, and you can see they're not quite concentrating because they need a quick comfort break, they need a quick cup of tea, they need something. And they have lost their own situational awareness, they've lost their own perception of their needs because they're lost in the reactiveness of today's work at this moment. And many of you have found time out to come and listen to this. However, you know yourself, the minute you're back into practice, you might lose that perception. So we all, as if we were focusing on human factors, we would look out for each other. We'd be working within the team to recognise that within it. A lot of this work was originally started within the airline industry, in which it was recognised that when accidents happened and they were catastrophic, people died, aircraft fell out the sky, and they looked into that and they looked at all the factors. It was so often human factors that led to the incidents, and it was fear. So in one aircraft, I can't remember which plane crash it was, but in one plane crash, in which it was quite catastrophic, the hostess that had just started that day, having finished her training, looked out the window and saw what appeared to be a fire in one of the engines, and just thought that she didn't realise that was the case, but reported it to someone else, who then took it to the captain, who then said, oh no, it's saying here that all the instruments are fine. So it was ignored, and when they uncovered the facts behind the case, they realised that actually that was the first case, that there was something wrong with the instrument panel that wasn't showing the fire, and the air hostess had been absolutely right. So the captain's perception was he was relying on the instruments and the equipment, and he believed that they were to be true and didn't take any notice of the air hostess. As a result of that, not as a result of that one incident, but in the airline industry, they take human factors so strongly that at any point prior to takeoff or at any point during the flight, if anybody at any level has concerns, they have the right to change the flight, to get the flight to land, etc., etc. The other things about human factors that approach, and I've talked about them, it's about teamwork. Because if we don't have teamwork, we know this, we keep getting told this, we know it, we see it, it can lead to a breakdown in the decision-making process and communication between members of the team, and lead to errors. And the culture, and many of us are not always working in a culture of openness and transparency. And so staff do not always feel safe to report issues. We'd like to think everywhere we work that that is the case. And it's how do we make it, we are part of the culture, and how do we work with that? So human factors and looking at that and looking at how those can impact on our patients is really important. Benefits, there's been loads of research about benefits of applying human factors. If we can have an awareness, we can understand why healthcare staff make errors, and in particular, which system factors. So often when we look at staff errors, you can see system failures that threaten patient safety. And in just being aware and having human factors approach to safety, you can improve the safety culture of teams and organisations and enhance the teamwork and improve communication between staff. Also, it helps us in improving the design of our healthcare systems. You're all involved in designing your acute frailty pathway, and when you do that, have you thought of taking a novel approach, many would say, in looking at human factors and looking at the risks and seeing how you might mitigate against that? So that's what we could do. I want to just talk about situational awareness now. And some of the problems that happen. If most of us would like to think we're situationally aware, so we can have it on the left-hand side. You can see we can have a high level of situational awareness, and when we have a high level of situational awareness, we become aware that there's a hazard, that this could happen if that does, if X will happen if we don't do Y. So we can avoid potential hazards. What so often happens, so is we're at the low end of situational awareness. If we're always crisis managing, and many of us in the NHS are, we're constantly reacting to the consequences rather than looking ahead to see what we can avoid. And many of us fall into a trap. So what happens is we have a particular incident, so it might be a rare event, but we then put in procedures to deal with the hazard so it doesn't happen again, without really understanding the situational awareness at the time and how we could move in our organisations from a crisis management to an avoiding aspect. So that's one thing that we can do. When we talk about perception, we're really talking, and I'm not teaching my mother to suck eggs here, but we're really talking about a whole new vocabulary. So we talk about confirmation bias when we look for something to confirm what we've already made a decision about. That authority gradient, there's still places and wards and areas where we work where people, perhaps healthcare assistants, are too fearful. I'd like to think this doesn't happen, but they're fearful. They feel that, oh well, the consultant said this, so I can't go against that. And all of us have our own mental models, our own mental model motor program, which we can all see situations from a different perspective. So what really helps if you try and develop your situation awareness is to become aware of what those biases are, be challenging within your teams, supportive challenge, so that you can change some of that. So if I show you, so if you look at this, what shapes do you see? So just to sort of have a bit of fun, really. Any offers on what shapes you see here? Anybody like to? Has anyone got their hand up? Although they may not have.
David's got his hand up. I'll just unmute you.
Hi, Dave again.
Like a little interactive session. So,
yeah.
I can see a triangle.
Yeah, you can see a triangle. It's really interesting because I can see two triangles. Other people, and I can, and you have to look away and look back again and not pay much attention. But if you all look away and look back again, you can actually see, at the moment, if you only see the triangles, all you see is the almost Pokemon little three-quarter round circles. However, if you stop seeing the triangles and you look back, you can very quickly actually see circles. And some of my colleagues say they see the circles first. They don't see that second triangle. So it just shows we have a different perception. So most of us would look at that and we see one triangle or two triangles, and we see circles with a bit of the cake taken from the circle. But other colleagues say, no, I don't see that second triangle. I see a whole black circle, and I don't see that. I really struggle with that because I can't see how they see that, but that just shows we have a different perception. I've shown this to quite a few people. It's quite fun. The other thing is, have you seen this, and what do you see with this one? Just give you a few seconds to have a look. What do you see here?
Dalmatian.
Yeah, there's Dalmatian in there, and I see the Dalmatian very clearly. What you're also supposed to see, and I must confess I really struggle with this, but in the middle, just in front of the Dalmatian, is a black pond, and the middle of a pond is a baby. So you can see the shape of a baby. Now, I can't point to it, but I always think there's a bit of a tree-looking thing in the middle of the black there, but there's a baby lying in the pond. So other people don't see the Dalmatian, but they see the baby. Can you see that baby now? It looks like it's or something, but people say it's a drowning baby, and we all see the Dalmatian, we don't see the drowning baby. So you have quite a bit of fun with this, but my purpose of showing you this is just really to look at our perceptions and how we each may see different things. And that's really important, particularly important in our team, in which we all think we're following the same direction, following the same course. And what we do is jump into conclusions. And sometimes we jump into conclusions and then concluding that our colleagues are jumping to the same conclusions when we're not. The other thing that's really important about our workload is our workload and our performance are linked. So at the left-hand side, you'll see a snoozing. You haven't got much. Not got much workload. Your performance isn't that great. As the workload goes up, your performance actually increases till you really start showing your personal best. But then, if the workload gets too great, you can see this little angry man at the other end. You go beyond your personal best. And actually, your arousal is so great that your workload is so great, the performance falls off. And I think that's really, really important because we all know the workload may be increased, but what can we do to support each other, ourselves and each other, about getting to the level of personal best, but without overloading and becoming to the end where you've got this Mr. Angry person who is no longer performing. Take that a step further, and what we're really saying is there is a level of workload at which performance falls off, and that's our danger area where we're likely to make mistakes. Equally, if you look at our brain and the effects of stress and the workload on our brain, if you think about the work we do every day, so at the moment I'm asking you to increase in your demand to think. You're doing a lot of thinking. I hope you're doing a lot of thinking. You're sitting in front of the computer watching this presentation. So your demands to act are less than your demands to think. When you're in the workplace, very often working with acute frail people, what you're doing is you have demands to take action and demands to think. And sometimes, in fact very often, you can reach the limit of your capacity. How do you know that within your teams? How do you know that with each other and your teams? Do you think like this? Are you thinking about where are those risks? Are they at certain times of the day? Is there anything you can do within your team to mitigate against some of this? If you know this, what can you do? If you think in human factors, you're predicting, proactively looking at risk before it happens. And as you can see, there's a limit of our capacity. And when our demands to think and our demands to act are in some sort of coordination, we're in control. But when our demands to act go way high and our demands to think, we become out of control and we can no longer manage. So that's really important to consider. There's lots of things we can do to reduce some of that diagnostic error about our perception. So just having insight and awareness of our biases, not relying on our memory, training in rules of probability, minimising interruptions and distractions. So if you look at the airline industry, they've got a sterile cockpit. And if you think about what's being done around medicines management and people giving out medicines without interruptions and wearing tabards and all sorts of things. That idea was brought to bear in relation to that. And to be able to give feedback to decision makers about where potentials are and the errors, and we can correct them before they happen. I've already talked about causes of errors. I just also want to tell us all, myself included, we have a bucket. I really like this. When I come to work every day, I have a bucket that's called home life. It's called reports I have to write, things I have to do that I know I haven't done, and my bucket is full. So I come to work with a full bucket sometimes, well, 3/4 full bucket. If I'm hungry, if I'm late, if I'm tired, Tarima, that did do a lot of work around this, human factors, say, think about your bucket. If you come to work with a full bucket, or if during the day you're hungry, you get angry, you're late, or you're tired, what actually happens is you overfill that bucket. And then your demands and your ability to respond and to recognise the situation you're in gets compromised. So I really like some work around this in which I genuinely do this. Sometimes I'm on my way to work and I'm tired and it's very early in the morning and I'm travelling and the train's late and everything else. I've got to get to a meeting. And I actively, in my head, empty my bucket so that when I go to wherever I'm going, to the meeting that I'm going to, I have a new bucket that's empty that can be filled with other things. So just think about your bucket and how you can empty that, and your team's bucket, especially when we're dealing with some of the most vulnerable patients. So how can human factors help us? It's about knowing ourselves, knowing others in the team, about the culture, and about thinking of halt and being reflexive. When you're in action, you're thinking, actually, I'm a bit tired, my risks, my likelihood of making mistakes might be higher here. What can I do? What can my team, if we talk as a team, to try and mitigate against that in the future? And there's lots of things we can do. So safety walkabouts, lots of things. I'm not like going through them. Actually having a reporting culture, that's a good one. It's really important. Having a high proportion of near misses reported actually is really good. If you've got lots of reported incidents, actually that's good, because if you've got less than 70%, that means that nobody's aware of what those are. They're not raising them. So they're free safety lessons for you. We don't often look at that. Multi-professional, when you meet as a team, are you looking at some of those factors? Are you thinking about those? Then we come back to the older person who might be frail. There's a lot of beliefs and attitudes about older people. People come with, professionals come with a perception and a bias that leads, and their beliefs about older people and the skills that's required to care for them, and they actually behave differently. So most of us working in acute frailty know that in all of our organisations probably there are areas of that organisation in which the attitude towards that frail person is not how we would like it. It's not how we want that pathway to be. And what can we do about that? And sometimes it's about the environment, and if we understood human factors, does that help us in changing some of that? I already talked about applying human factors. So I think one of the things is, if we look at our pathway, which we're all doing, everybody's looking at their systems and their pathways, what systems in that pathway can threaten your patient's safety? What can you do proactively to learn before a mistake happens? And I think the other thing is, it helps you to think about risk differently, and the risks that we put on the system and the system puts on us, and the recognition that is normal, performance is variable, overload is a killer, and bad things happen to good people. So what can we do? We know all that. So we put it to the back of our minds, but actually how can we bring it to the fore of our mind and think about it differently? The other thing is that what we need to do, and we know in acute frailty as well as in other areas, we need to tackle variation all over the place, and even in our own places. There's too much variation. We're not improving the reliability of what we do. And what human factors can help us is just give us a different way, a different lens to look at. And we need to be able to support people working interdependently. And even if that's new and in different teams every day. I think what Acute Frailty does is it brings everybody together to focus in on the patient's journey, so we shouldn't forget about the risks in relation to that. So the questions you could explore in your practice is about what could go wrong, what causes that to go wrong, what are the consequences to those acute frail patients, how can we redesign handovers, or how can we redesign parts of our system to reduce those risks. In I think it's George's in London, they do a regular after-action review. So they ask questions about any time there's an incident, but I would say, and so that you can do this post-incident about what was expected, what actually happened, why was there a difference, and what have we learned, and what are we going to change as a result. Very often we're jumping in and making changes without any learning and why we're putting them in. We're making a change for one terrible event that happened rather than looking at, we know this could happen again, so what can we do that helps us mitigate it. And I think, Dave, that question about allowing a patient with capacity to take risks, that we become complicit in that, is a very valid one. And in a way, the after-action review won't deal with that. Human factors might be able to. So in summary, understanding would help us reduce the risks and go further. So what I wanted to do at this point was open it up really, I've just said that, is to ask if there's any questions. What I'd really like to do is for you to put your hand up and let's have an engage in a debate and follow on from that. How do we go forward? How do we allow risks with this very vulnerable group of patients? Thank you. Any questions? Any interaction?
Okay. Like Mandy said, if you've got a question, just use the raise your hand option and I can unmute you, or feel free to type in a question if you haven't got audio available on your computer or laptop.
And what did occur to me, the last time I did a webinar, some people said they were desperate to ask questions and they couldn't because their computer system, their phone system wouldn't let them do it. Please, please, please do email me. Even if you don't remember my email, I've given you the generic @FN email, but you can email in through the web, and if you go into the web page for the Acute Frailty Network, you can do any email. It just says contact us and it gets to the right person. So if you just put in there that you want, you've got a question, you've got a desire for something to happen, for us to work as a network with you in relation to risks, we can address that in that manner as well. Have we got any?
No, it doesn't look like we've got any questions at the moment.
Oh, come on, please. Adele, have you got anything to say? Or Emma, or Jane, or Jason, or Judith, or Karen, or Kath, Nye, Sarah, Siobhan, anybody. It's very difficult when you do these because you get no feedback when you're going. It's just I really want us to think about risk and risks with our patients in a different way and really expose both our human factors, but equally what are those issues for us in frailty. No?
No, still nothing at the moment. Oh, yes, we've got a question. David's got his hand up, but we've also got a question. So I'll just unmute David first, Judith, and then I'll read out your question. Okay. Hi, David. You're muted.
Yeah, hi. Sorry, I'm happy to. If nobody else was going to jump in, I would say something. But if there's another question, I'll hang back and let us answer that one first.
Oh, okay. No problem. I'll just mute you for a moment. Okay. So the question. Oh, looks like Judith came up with a question, but the question panel is blank. So I'll unmute you again, David. There you go.
Sorry, David.
So the question that we're thinking about in Plymouth is we are attempting to follow the best practice guidance that we've got around discharge to assess in people's own home. The home first principle that ESIP have talked about. We've got a community hub that we are looking to take patients to for their first assessment. And within all of these things, there is the question about appropriate risk taking.
Yeah.
And there is there's always a concern about saying, well, you know, I can't send that patient home without the assessments because that's not what I've done. And I guess what I was hoping to get from some of the webinar was some practical examples of how to deal with some of those confidence issues. So the human factors stuff I'm aware about, but I see it as less relevant in this context when we're talking about trying to change people's attitudes, rather than talking about perhaps minimizing risks that we know are there, because we're saying that the risk is probably lower than the perceived risk. So I suppose I'm trying to think about how do I take people on that journey to say the recommendation is home first, people still aren't doing it. So how do we take that step?
And I think it comes back to it's trust, isn't it? It's trusting each other. And I know certainly at Medway, where I work with ESIP, Home First has been taken forward. It's been recognised within the Acute Trust. It's been embraced. It's moving forward at pace. And their risk, what happens, they have actually got a community hub that anybody from acute care can refer into. The community hub then responds and goes out to the person's home within 2 hours of the call and the patient going home, and then the assessment happens there. What then happens, naturally what will happen is there will be some people who went out, and then you would find that you felt that now they're out, actually it's not that safe. And how do you wrap round services to provide that safety at home? Because you can't always predict what those dangers will be from a hospital. The person has to go home to see them. That shouldn't result in the patient then being returned to the hospital. What we should be doing is looking at, okay, so let's rehearse some of these scenarios. What can we do then at that instance? So the person goes home and the house is full of flies and some maggots in the house or whatever. What needs to happen there and then? Because it's not appropriate. The person doesn't need to go back to acute care. So I've heard of this issue that's arisen somewhere else, and what the person then did was they had the Home First principle brought in all the partners and enabled the council to respond that day and go out and support the person in the home and enable them to stay at home. So it relies on all partners, and I think you do, if you're setting up that Home First, you need those conversations about what presents risk. What are the risks? How will you mitigate against those? Where's the support? Often for community staff. I've worked in acute care and in community and in primary care actually, and so there's a different perception of risks in each of those areas. But if you come back to the patient, what's the risk for that patient? How can we minimise and wrap round so that we offer the patient something that's different, is where we need to be going.
Yeah, and so I'm aware of that, like, you know, toolkits that you can use to assess suitability for things like ambulatory care. I guess I'm looking for some practical tools that I can use to try and test out whether they would be more helpful at allowing people to change their mindset. So, you know, if there was tools that people were using that said this is how we assess a patient's suitability to access Home First, you know, some frameworks that people are using, maybe some case studies that people have got about, you know, the positive risk, or I know that we talk about the risk that is inherent in keeping people in hospital, but that sometimes seems a little abstract.
Yeah, no, and what I'll do outside the presentation is I'll put you in touch with Lisa Sladden at Medway, and also try and get some information that we can put on the web page around that and around some tools that might be useful. I'll put it back to our team.
Okie dokie, thank you.
But thank you for that and your input. And any other comments? Have we got any other questions? Did you see the question? Has it now come up?
Yeah, we've got a question now from Judith. The question is about whether we set a higher bar for frail older people returning home because we think that we should be solving all their problems before they are allowed home. We set a lower bar for other adults.
Absolutely, I totally agree with that. I think, and I find myself in that circle as well. I think sometimes we absolutely we would allow somebody who was less frail, who was more, in our opinion, able to go home, But what right, and I'll come back to what Ian Sturgis says, what Brian Dolan says, what right do we have if people are frail and they're elderly, their likelihood of life expectancy is less than 1,000 days. That's about 3 years, just over 3 years. What right do we have to keep people in hospital when they have so little time back home and require to have a quality of life in the home? The longer we're keeping them in hospital, they're decompensating, they're less likely to be able to return home. What right do we have? And I would say that what we do is we display a very paternalistic attitude towards that, and I think that's the issue.
Okay, thank you, Mandy. We've got another question from Manisha Datani. Manisha's question is, we'll be looking to open an acute frailty unit at our trust over the next few months. From a pharmacy point of view, what do you think we should be thinking of regarding risks?
I think from a pharmacy perspective, that's an interesting one as well. I think the most important thing, and what we should all be doing, and if you've got pharmacy involvement, is looking at polypharmacy and looking at how easily it is, both in acute and external in the community, to get that polypharmacy support and medicine reconciliation, and being able to stop as well as start medication. So I would say look at tools, use tools like the stop start, the anticholinergic burden tools, and other tools like that to look at. From a pharmacy point of view, I think one of the biggest issues is our frail older people come into hospital. This is hugely, I'm falling into the trap of making judgments as well, but very often in my experience, frail older people come into hospital, they've got in their bag 5 or 6 tablets that they are supposed to be on, and at home, if you actually were at home seeing them, they've got a cupboard full of 20 different tablets. And in fact, I have an incident in my own family where an uncle of mine opened the cupboard one day upon asking if you had any paracetamol by a member of my family, and he said, "Oh, take your pick, I've got all of them." Had a cupboard full of tablets. And when I asked him, he's a frail older person, when I asked him, well, what are they all doing in there? He said, "Oh, well, sometimes I take that pink one because that's better than that red one." And I make no joke, this is exactly what he does. And he just, on a daily basis, looks which tablet he thinks might suit him. So I would say, from a pharmacy point of view, how are you looking at things like that within your acute frailty unit, both in the acute phase, but actually how are you supporting that issue of polypharmacy and making sure that there really is no issue of polypharmacy, which there probably will be, for that patient. So I think pharmacy engagement, pharmacy involvement in acute frailty units is vital. Thank you for that, Manisha.
Okay, it does look like we've got any more questions at the moment, Mandy. So
Please do provide feedback. I'm more than happy to change presentation, to lead a presentation in the future in which we could explore some of these in more detail. I think the discharge to assess and the taking is really a good one that we could perhaps do a webinar on, and if you feel that that's important, please do contact any of us and we'll take it forward. And meanwhile, I will take some of those questions and issues back to both the Acute Frailty Network and to my ESIP colleagues as well.
Okay, lovely. Thank you, Mandy. So I think it's time now to bring the webinar to a close. Just to say thank you to everyone for taking the time out to join us today. And thank you to Mandy for presenting the webinar today. It's very much appreciated. Like Mandy said, if you do think of any questions or if you've got any comments, please feel free to email frailty@nhsselect.org.uk. And also just a quick reminder that the recording of this webinar will be available on our website shortly. So goodbye from both of us, and thank you for joining us today. Thank you. Goodbye.
Thank you. Bye.